Bismillah ar-Rahman ar-Rahim. Thank you so much, Dr. Bandesha, for giving me this opportunity. Uh, I'm sorry about yesterday. I missed it, so I'm just going to show a couple of slides of yesterday talks as well. Uh, so, as the topic says, I'll just briefly touch the all the advancements which have been happening in the uh, EP field. As you know, it's a very uh, dynamic subspecialty, growing very fast. The first which comes to mind is the newer ablations, which is the AF ablation. It's a very a successful mode of ablation, which sometimes achieves success in the range of more than 90%, 85 to 90. I am talking of cryoablation now. So as you can see, this is the standard approach. The only difference is that with us, the electrophysiologist, probably the betterment in the technique is that we do have the skills to hit the fossa quadrant by quadrant. So if I want to go to quadrant, I can go by design, and similarly if I want to go to the anterior inferior quadrant, same is the case. And obviously because the gadgetry is quite bulky in the left atrium, so the right quadrant is very important to gain access to. So here you can see this is the one of the so this is an achieved catheter. This is the occlusion of the pulmonary valve, and that's the cryo balloon. So freeze energy will be delivered, and the vein will be isolated electrically. As I said, huge success, tremendous success. In fact, sometime if it recurs, a second procedure can almost obviate the arrhythmia. So as in this patient, you can see a sinus rhythm has been achieved. The second EP technique which is getting momentum is the cardiac resynchronization therapy. These are devices, as you can see, the ECG. This is a standard procedure with 3 leads, and this is one of the posterolateral branch of the coronary sinus. And with the help of this device, the QRS, you can see the width of the QRS, which has significantly been narrowed down, and this is a curative procedure. And sometime with the success with this device, it changes the life, and later on the cardiac output, the ejection fraction, and the quality of life changes altogether. Not stopping there, and the newer modalities have come into effect. So one is the His bundle pacing. We have also tried a couple of them in our setup. So as you can see, this is again an ECG with a wide QRS complex bundle, and this is the device, the His bundle. So like a standard device, this is an atrial lead, and the other lead is fixed onto the His side. And as you can see, post procedure, the ECG and the QRS has narrowed down, resulting in vast improvement to this patient. We've been following this patient for the last 2 years now, and this patient has significantly improved in terms of symptoms and quality of life. A step further, the newer one is now left bundle pacing. Again, as you can see, with this left bundle pacing, look at the QRS width. So have a look at the QRS width. This is how a left bundle pacing would look like. The lead will be placed somewhere here on the membranous part of the septum, and by this is there you can either selectively or non-selectively engage the left bundle. This is the view in the echo. This is how it would look on a fluoroscopy. And have a look at this result. So again, significant improvement with this left bundle pacing. And in fact, I'm not going to show the data, but the data which has come up recently, General American Cardiology, in fact, left bundle pacing or left area pacing is probably gaining more momentum than pure CRT, yeah, or the cardiac resynchronization therapy. Another tool which we have got in our momentum is the laser extraction of the leads. Luckily, we have this system in our setup in AFIC. So, Alhamdulillah, whenever we get leads which are very difficult to extract or which were previously left alone because of the non-availability of this system, now we have this laser extraction and the laser lead system. And as you can see, bit by bit, the leads are going to be extracted. This was a difficult case. I think more than 10 years of the time of the leads, very heavily calcific. So I think in this one, I didn't use the laser catheter and I used the mechanical tool, the tight rail. And it took me about 2 to 3 hours, but it's a very tough one. But I managed to get both the leads out of the heart. Then we have the advancement in the arrhythmias ablation techniques. And as you can see, this is an ECG with outflow ectopy, classic outflow ectopy. So this is how it would look like. So left main, then the coronary sinus, the catheter up going into the greater cardiac vein, and it was to touch the LV summit. If I hadn't got another tool, it would have been very difficult to ablate this arrhythmia. But luckily, because all of our colleagues in Pakistan, we've all got mapping systems. So with the help of these mapping systems, now we know exactly where the spot is. So in this case, it was the left coronary cusp, and I ablated about few millimeters away from the left main stem. So this is an advancement with the help of this 3D mapping system. Another of, in fact, our serving soldier, as you can see from the ECG, outflow ectopies. I think he was also having runs of non-sustained ventricular tachycardia. So have a look here. Again, the same scenario. The catheter, this is the ablation catheter, that's the Judkin engaging left main stem, and as you can see, the origin of the left main along with the two arteries, and I'm abutting about the outer surface of the left of the summit of the LV. And again, with the help of this system, it was very helpful because this guided me to a specific point, and it was ablated right there and then. And Alhamdulillah, the ectopy or the VT was successfully terminated. Have a look at the colors. You can see the colors spread out from a single focus, and this is so helpful sometimes, because otherwise you can see it would not be very easy for us to do it non-mapping wise. So another of our patient, a very bad VT, you can see the VT. Again, with the help of this system, as you can see the color spread. So this is the catheter in RV outflow. That's the single catheter in the RV outflow. And you can see this point is the earliest source or the origin of the tachy or the VT. And with just a couple of ablations, the arrhythmia was gone. And you can see in the bottom below tracings that the arrhythmia is eliminated. We had another case, again a very complex case. He was ARVC, I implanted an ICD many years ago, and now he was having slower onset VT. So it was very difficult because the device would not shock. The cycle length was such that the device, you don't want the device to shock at that cycle length. So this is the ECG. This was the slower VT. And so what we did in this case was we chose the epicardial approach. I think this was the first ever in Pakistan, where we went in. This was a device patient, and we did a epicardial approach procedure. As you can see, this is all epicardial, and luckily, I'll just show you. This is the catheter, one of the basket type of catheter. And this is a rhythmia system. We have the system which is called rhythmia. So this help us in localizing the point and successfully ablating it. Alhamdulillah, since then, this 2 years now and no VT. I think this should be the last one. This is an interesting case. It was another VT, fascicular VT. And in this VT, what I did was I did a transeptal with the help of ice, one, but not the standard what you would like to have. But with this ice, I still managed to get across, and that's the mapping system. This is LV, and this is also pointing out the origin of the arrhythmia. You can see the ablation catheter here. This is the papillary muscle, and this was the site roundabout, and the arrhythmia was successfully terminated. So with this, I thank you all. Thank you so much.